My name is Phil Perazio, and I'm a urologic oncologist, a surgeon. Like many of you, I absolutely love what I do, and I would not choose another profession. But I have struggled with professional identity, practice efficiency, and wellness over the years. Operate with Zen is a podcast designed to explore a mindful approach to surgery and to being a surgeon. By discussing these struggles and mindful solutions, I hope together we can create a community of strong and healthy surgeons. Enjoy. Welcome to this episode of Operate with Zen. Today, I have the great pleasure of being joined by Dr. Kristin Chrouser. Kristin, introduce yourself to the audience.
Well, thanks so much for having me on, Phil. My friends call me Chrouser. I'm a urologist. I do general recon prosthetics and pretty much all the microscope cases at the Ann Arbor VA. Which is actually where most of my clinical practice is situated. And I wear some other hats too, the HRO champion at the VA, as well as the site director for our postgraduate surgical quality and safety program. And then I also serve as a faculty associate in the Michigan Medicine Wellness Office.
Well, amazing. And it's wonderful to talk to you today. And thanks for letting me call you Chrouser. I think that's a high compliment. And one of the things I find most fascinating about your career and your interests, I mean, your academic interest is in the surgeon's response to intraoperative stress, which is basically what we do on a daily basis, but helping kind of define that and make it better. So I think that's a great place to start. If you don't mind, tell us a little bit of the backstory. How did you get on this pathway, and, where's it taking you?
So I'd start probably back in residency. I remember I was a junior, probably like a PGY2, and I started having this awful, like, aching hand pain. And this will date me a little bit. This is back in the day we were doing tons and tons of open cystectomies and open prostatectomies. And I was the assistant. So I was, just they'd like hold the bowel back, and I would hold the bowel back. And I mean, I was like wondering, like, did I have arthritis or something crazy? And so I actually went to the doctor, and they ended up having me evaluated, and the surgeon was like, well, he sent me to PT, and they said, well, you just must need to get your hands stronger. And so this physical therapist gives me all these hand exercises. It makes everything worse. And it turned out that I was just super, super flexible. And so in order to hold anything back, I had to activate every muscle in my hand. And after I sort of realized what the issue was, I realized that my colleagues just stuck their hand in there and relaxed their hand, and their hand had enough natural tension that it would just hold things back. And I think for me, it was the very first realization that, okay, we're not all the same. And there might, be something to think about in terms of, well, everyone's a little different, and how I'm going to respond to surgery long term might be different than someone else. So then during my fellowship, I did a lot of work internationally, and so I found out what it was like to do a TURP without a camera, which is why old school urologists would get urologist neck, right? I found out what it was like to operate and do open surgery on a table that didn't raise up or didn't lower correctly. How do you do when the lights go out in Africa and you're operating with a camping headlight, you're trying to do a vesicovaginal fistula, what your posture's like. So I think also there, then realizing that there's this huge impact of your environment on whether or not you have pain during surgery and things. But early on in my practice, I think my first day in the operating room, as an attending, I had 6 flexible ureteroscopies and no residents, and a really green first assistant, scrub, who didn't know what she was doing. And I had such bad neck pain on the way home that I couldn't even look at my blind spot. And this is like before cameras. And so you really did need to actually look over your shoulder. Um, and, that was kind of a sort of wake up call, and I needed a little bit of PT. But a bump in the road relative to what other people have like really endured, like serious, medical issues and injuries and surgeries. I've never had that. But I think for me, it was this like niggling realization that, I didn't sort of expect this to be this bad. Like thought it would like hurt a little bit, but surgery, I mean, but I didn't really think that I would walk out the door and not be able to safely drive home. And so I think from there on, I decided to take a little bit more proactive approach and do some preventive things. So I had, I learned some exercises, and I got massages, and that was sort of how things were for a long time. But then I had two friends with pretty serious musculoskeletal injuries. And I had like unfortunate sort of front row seat to the like real misery of that. And so I think that, and one of them even like retired from operating. So I think that was the beginning of really thinking about, well, maybe there's something that needs to be sort of thought about from like a more system standpoint in terms of whether we should provide more education and more adjuncts for people to essentially be able to operate in a more safe way. I will say that how ergonomics kind of made its way into like my research and educational interests was a little bit more circuitous. So to rewind, like during residency, I was interested in complications and sort of what we used to call outcomes research. And so I spent a lot of time in these big surgical databases, and I was always surprised at how you have all of this data about the patient, but not much about the surgeon or the hospital or the context. And then when you get out in practice, you realize, well, that's the stuff that makes or breaks a surgery. It isn't usually just the patient factors. And so, I started really getting interested in sort of teams and the environment and stress. And through that process, I realized that like one of the things that can impact patients is the actual like mindset of their surgeon and whether their surgeon's in pain. And so, it's one little tiny piece of the big puzzle of how do you make sure that we operate well even under stress. But that's the one that I think has probably taken off the most in terms of just educational products. And I bumped into one of my mentors at one of the AUA meetings probably 10 years ago, mentioned what I was doing in terms of surgeon stress. And he was like, oh, I'm going to introduce you to Susan Hallback, who's an ergonomicist at Mayo. And that was probably 10 years ago, a relationship that, we've done a fair amount of research and educational work together, and are now both working with the new Society of Surgical Ergonomics. And so I think that, that those two sort of streams of the professional interests and a kind of personal concern sort of merged at that point. And the rest is sort of history.
Well, it's amazing. It's an amazing story. And I just want to hit some of the high points that you brought up early on. You talked about how you recognize that we're all not the same. And I think this is one of the most fascinating things in the operating room, right? Even glove sizes don't make a whole bunch of sense, right? And I think I joke all the time, I do a lot of kidney and kind of upper retroperitoneal surgery. And it's because my hands are terrible for the pelvis. I have these big fat palms and short fingers, and just getting them into tight places is really challenging for me, right? My hands are very different than some other colleagues. And I think it's really funny, and sometimes in a not so funny way, how we're kind of pigeonholed into our instruments and our gloves and what we use in the operating room, and trying to individualize things is really challenging.
That's really true. That reminds me, like, my chief or chairman when I was a resident at Mayo was Mike Blute, and he these huge paws, and every once in a while there would be something, where it was like a small narrow area, and he'd be like, Chrouser, get your witchy little fingers down in there and horse that thing out. And at the time I remember thinking, OMG, but like here I was able to actually like physically get my finger somewhere that, that he couldn't, and he was like the man. So, it's really true. We're all different, and we do tend to end up doing things that, like our body is capable of doing. And there's certain surgeries I wouldn't be able to do, I don't think, because I don't think my neck could handle it, but other people can. So.
Yeah, absolutely. And, it's funny, we think a lot of the transfer of skills now to robotic technologies, where it takes the hands out of the equation, but it introduces a whole bunch of new kind of ergonomic and kind of health issues in the operating room. So just kind of thinking of that evolution too, as you were talking about that. And I think one of the really important points you brought up is ergonomics in surgery is serious, super serious. Career-ending injuries, early retirement. These are not one-offs. This is becoming more and more common. So if you wouldn't mind, just if there's any data you'd like to share with us or let the audience know, what's kind of your current understanding of how, poor ergonomics or poor outcomes in the operating room can lead to shortened careers?
So the numbers are kind of all over the map, and I don't actually trust a lot of the survey data because there's some likely selection bias in it. And in fact, I remember early on trying to publish a series in urology, and like the main journal rejected me, and they're like, oh no, there might be too much bias. And then I was actually able to get an ergonomics question or two into the AUA census, which is within our specialty, like a broad survey that wouldn't be biased by topic, because they add these extra questions in. So no one going in to do the census knows there's going to be an ergonomics question. And it turned out that, something around 40% of people have issues. So like, that's a lot of people. And unfortunately, the worst subset of those people were women and younger surgeons. And so like, that doesn't bode well for a specialty like mine that's becoming more and more heavily women, and, younger and younger in terms of the general age of urologists coming up, especially with COVID, as a lot of people have retired. And so we have this, there are not going to be enough urologists. We're now at high risk, and we have these sort of work-related potential injuries are going to take people out of the game. So it's a big deal. I think it also helps people to understand that, like, pain rates and sort of location of pain vary by surgical specialty. They vary by surgical modality. And in urology in particular, we cover everything. I do open surgery and robotic surgery and endoscopic surgery, but there are people out there who do all that plus lap and robotic. And so, we as a specialty cover the entire gamut, and each of those modalities has its own set of risk factors. And so I can't go through all of them, but essentially you can pretty much guess what they're going to be. Like static postures where you're still and where you're tense are the worst for people. And so I do a fair amount of work with residents, and I spend a lot of time watching the residents. And they'll get this, like, they find the stone and then they freeze, as if they think that if they move that the stone is going to move. And then I'm like, okay, now you found it. Now like stand up straight and relax your shoulders and relax your hands. But when you're in the zone and you're really concentrating hard, especially as a trainee, all you're thinking about is, I don't want to screw up. I don't want to get a bad grade. I don't want to hurt the patient. And the last thing they're thinking about is their neck or back or whatever. But in 20 years, they'll be feeling it. So we work on it now.
No, it's smart. I always love when you're with junior residents and say, I'm guilty of this too. Still, you're trying to torque an endoscope or whatever it may be, and your head works with the screen. Like if you turn your head, the screen's going to turn a little bit in the direction you want. But obviously things don't work that way. But maybe somebody smart can figure that out one day. But that is definitely our natural inclination. I think it's really interesting what you say about women and younger residents. For lack of a better explanation, I mean, most of the stuff in the operating room is sized for men. And it shows just how long we have to come in surgery to make sure that we're kind of evening the playing field and making it equitable for all of our participants in the operating room.
Yeah, you bring up a really good point, because I've talked to some people in industry, and actually, like the whole like anthropometry, I can never quite get that word to come out sounding smooth, but is the sort of study of the length and width and size of things, of people's body parts. And so all of the equipment is actually sized for like the average surgeon's hand size, strength in 1986 or something. It has not been adjusted. So obviously everyone knows that there weren't that many surgeons, and almost no female urologists back then. So trying to advocate for companies to take that into account, it's a big deal. The problem is that our government has not made it easy for people to adjust equipment and designs after they're approved, and that's unfortunate, because it means that the stapler is really hard to fire. You're just going to have to suck it up because it's too expensive for that company to redesign it. And I think that's an unfortunate side effect of just the way the system works.
Yeah, very fair, very, very fair point. Some of the skeptics of kind of the ergonomics literature say, hey, listen, if you look at 40, 50, 60-year-olds in other fields, 40% of them have ergonomic issues too. And so it's not surgery specific, it's age specific. How do you kind of interpret that criticism?
So I think that there's some fairness to that, because obviously over time we do sort of break down. Like the snap, crackle, and pop of my joints going up and down the stairs is not what it was when I was 20. But I will say that I have a hard time believing that if you have an acute exacerbation of your pain after doing a certain activity, that your doctor wouldn't say, stop doing that. That's usually what they say when you come in and say, I have tennis elbow. They're like, well, take some time off, switch to another sport, do something else. The problem is we can't switch to another sport. So I agree that there's probably a fair amount of overlap, but I do feel like there's also a large degree of underreporting. In other words, most of the literature shows that like physicians very rarely actually seek medical care. Some of them will sort of self-treat, and sometimes in like not terribly healthy ways, but we're slow to go to the doctor or PT, and so I don't think we even quite show up in the numbers like you would expect. So yeah, I see people's point, but I also think that there's a degree that's not reported. In other words, someone with back pain versus someone who has back pain and can't do their job, those are two different things.
Yeah.
So fair criticism, but I don't think it changes the fact that in any other, in like on an assembly line, if OSHA came in, they would, ding the company for having designed the work not to fit the worker. So, and they would shut the line down until it was fixed. And yet they don't have access to the OR. And when people like my colleague in ergonomics comes in and does a RULA, which is like a upper extremity assessment that looks at angles and postures and weights and how long people are in these postures, she can give you the number that says this is dangerous, and at which OSHA would shut it down. And almost every surgeon we've ever done that research in and calculated those numbers for, they would shut us down too. So we're outside of like established guidelines.
Wow, that's pretty incredible. That's a pretty incredible statement. My thought on that was always, well, listen, if it is 40%, and I just want to say we're using 40%, we don't know if that's the number, but we're just using it as a reference point. There's no reason we can't make it better, right? I mean, we shouldn't just accept that as the baseline, as the standard. That's the people who are in pain after surgery. If that's the number, we've got to figure out ways to do better.
Absolutely. And And I really feel strongly that, as educators in particular, like if we can train somebody to be a compassionate urologist and have a broad knowledge of the field, excellent technical skills, but we have done them a disservice if we haven't taught them to do that safely for a 40-year career. And that's my passion, is that, like, there's such joy in surgery, and it's just like such a privilege to take care of people. And having talked to people who had to give that up early, and just to understand like what that took from them, I just don't want to ever see any of my trainees in that position. So we're going to fix it, or well, we're going to work on it.
Yeah, absolutely. And listen, that's why we're here together today. I mean, I think that the synergy here is, while this podcast is focused on mindfulness, it's really focused on sustainability and building long, healthy surgical careers. And so if we were going to go into some specifics, just let's give some basics on how surgeons can stay healthy physically in the operating room, and then we can go, in any direction from there.
So, I mean, just sort of my basic tips would be to kind of based on the type of surgery you're going to do. Most of us tend to be like it's a lot upper body, neck, and it tends to be leaning forward, right? So, before you go into the OR, stretch in the opposite direction than that, like, it just makes me want to stretch now. And then, so just do that before your case. Most of us go run to the bathroom really quick before a big case. Do that stretch right before your big case. And then I have kind of come up with a little bit of a mental checklist that I try and do like right after the actual OR full stop checklist, because it's a just logical time to do it. And that has to do with adjusting my environment. So the table height should be adjusted to the tallest person. And that means if you're the attending and you're trainee 6'5", then that means that you need to be on a step. There's no way that the trainee can go on their knees to do surgery. So, we need to think that, it does need to be adjusted to them. And if I'm the tallest one, then someone else is on a step. But essentially, you first adjust the table, you adjust your screens so that your eyes are usually about at the top of the screen level, because that puts you in a gaze down position at about 20 degrees. And that's the most relaxed position for eye muscles to be in. If your screen, in an ideal world, your screen should be about 3-4 feet away from you. And that also has to do with how your eyes accommodate. A lot of this depends on screen size. So these are real, like, general rules of thumb. And then things like, your foot pedals need to be in line with the rest of your body. You want your body to be facing your screens if you're using a screen, not like operating here and turned out to the side, like we used to when we did lap and it was all on a stack of, the insufflator and the light and then the screen, and it was always off to the side. So that's actually what sparked a lot of the interest in surgical ergonomics. Was when lap came on the scene, suddenly surgeons started getting awful pain, and it was because of the equipment around them wasn't arranged logically. So booms from the ceiling, things like that can help. But when you first get in, that little checklist about the table height, where the screens are, where your foot pedals need to be in line with your body. If you have standing mats, don't call them princess pads, by the way. Those are helpful for some people. And then intraoperatively, so that's kind of the environmental setup. And then intraoperatively, if a case is pretty long, like, a lot of the studies were done if the case was greater than 2 hours, but I'd say if the case is greater than like 90 minutes, I'll remind my nurses that we're going to do intraoperative micro breaks. And so this is actually something that my collaborator was, she was on these initial trials looking at if we stop and stretch every 20 to 40 minutes, throughout a case, what does that do in terms of surgeon pain? So the data shows that surgeon pain drops, that mental acuity goes up, and that case time doesn't change. So to me, that's a win-win-win. And I have religiously done micro breaks during my microscope cases for years now. And I went from having to have like 2 massages just to recover from a case to now I rarely get one. And when I do, it's more for fun than for pain. And that's a huge difference. And they're quick. They're like 60 seconds worth of stretches. And I've gotten like my whole crew and interested in it. And like even the anesthesiologists sometimes are like, oh yeah, I'd like to be in your room because you stretch and you remind me that I need to stand up and stretch. And so it's like, to me, it's a great way to kind of, kind of remind ourselves that we're all a team. And yeah. So micro breaks, and there's like an app too. If you want like a reminder, you can set the timer and it will remind you, and then it stops and will lead you through the stretches. So for, there's lots of ways to do it, but
What's the app, just so everybody can hear it?
it is called OR Stretch, and I think the website is orstretch.mayoclinic.org. But if that doesn't work, just Google OR Stretch, you'll get it. And then the other thing I would suggest is think about all the adjuncts you use that can make your your musculoskeletal pain worse. So I don't wear a headlight anymore. If I'm doing a case where I think it's really needed, and I'll ask the resident to wear it, unless they have pain, in which case nobody will wear it. But that extra weight for me is just, that kind of tips me over. If you wear loops, you really need to be conscious of how your head is on your shoulders. So if you think of a bowling ball, if you're holding it above your shoulder, that's not hard to hold. But if you rock it out and you're still holding on to it, the amount of torque and strain that puts on your neck muscles goes way up. So if you're going to wear loops, you just need to make sure you keep don't swing your neck forward. And if you do, don't do it for very long. Other things to think about are wearing, like a lot of us wear a lot of lead. Try and wear 2-piece lead, or lead that has a waistband that cinches to sort of to keep all of that weight from going on your shoulders. There's lightweight lead now that could also be helpful. So just things like that, where there are certain accoutrements we use in our practice that can just make things a little bit worse. And then outside the OR, I would advise people, especially if you're doing a lot of clinic or you're doing a lot of research at a workstation, to get a good ergonomic chair, to get either a standing desk or a riser so that you can change positions, to have somebody come in and take a look at how your chair is adjusted and how your desk is adjusted, because a lot of typing can be really hard on your shoulders and neck. And I think what used to happen is people used to go to clinic and they would recover from their OR. And now we go to clinic, and since we are not writing a 5-line note in a chart, we're actually typing a note often, or we're clicking a bunch of orders. We get no recovery. And so the same muscles that are exacerbated by what we do in the operating room are now on top of that. There's like yet another layer in clinic. So, getting that at least optimized is helpful. Try to dictate when you can, things like that. Yeah, so those are like the practical things that I would think about.
Yeah, those are some great pieces of advice, and I just want to walk through some of them because I think they're worth getting into a little in more depth. I mean, stretching not only pre and you mentioned during the micro breaks, but after also, I think is huge. And you think of all the flexion we do; it's all kind of forward anterior chain flexion, which puts a lot of stress on the posterior chain. And so extending and kind of working on opening up your cervical spine, thoracic spine backwards is a great thing to do at the end of the day. You can do it just standing. You can get a cheap foam roller. I have a colleague who likes to come home and watch the news upside down on his bed because it, with his neck, backwards, just kind of opens up everything in the posterior chain. And it actually makes a tremendous difference.
Yeah, that's really true. One other thing I would mention is this idea of postural resets. And you'll like this because you're much more, I think, of mindful human being than I have learned to be yet. But I have learned a little bit of it with postural resets. Like I tend to be like super focused, and then I'm like, ow, and what a postural reset is sort of being aware of what's happening in your body. And so for me, it's learning to kind of get out of just being in my head and realizing, oh, my head is way, way too far forward right now, and I need to be more upright or whatever it is. But it's just realizing that I am like, my body is in a position that's not ideal, and I need to minimize the time I spend in those postures. And so if you're going to minimize the time, you have to have, some sense of awareness of I've been here too long. And I think that degree of mindfulness is not natural for many of us who like to be in the zone, so to speak. But you've got to learn that if you're going to, if you're going to like operate for a long time. I do find that honestly, operating with residents is helpful because, they'll be doing something that I'm not worried about them screwing up on. And so like, I will start looking at rather at what they're doing. I won't be looking at that. I'll be looking at how they're standing. And so it's made me more like able to kind of back up and look at the situation holistically, like, where's their body? Okay, what can I tell them? But then I have to realize that like, that's not natural for me either. So those postural resets, I think that's a skill that needs to be developed, but having trainees start now is good. And for people out there who have issues and haven't started, it's never too late to start.
Yeah, great plug. And I'll just kind of tie it into a couple of mindfulness examples too. There's lots of ways to meditate, but Zen meditation is one of the common ones. And Zen is very posturally focused. And so the idea is to be able to sit in a very comfortable position. So it's typically lotus where your legs are crossed, which is not so comfortable for a lot of people, but you can elevate your backside to kind of help do that. Spine basically straight, so that you're stacking the weight of your spine and your head the way your spine was designed to work. And just like you said, how we should operate, chin down slightly so that you're carrying the weight slightly forward. That's how our head is designed to sit in a comfortable position. It's not designed to be up in the air or off to the side. It's designed to be straightforward and chin down. That's the way kind of our cervical spine plugs into the back of our skull. And those are absolute kind of correlations between surgical ergonomics and meditation practices too.
Yeah. And, I think that also makes me think of the fact that like, you have to listen to your body. That is something I think that surgeons are not taught. In fact, we're taught the opposite. Ignore your body. It's supposed to hurt. You're tired. It doesn't matter. You're angry. It doesn't matter. Shut it all down. So there's this surgical macho culture that says, pushing through is a virtue. And granted, there are times where, pushing through is a virtue. I'm not saying that's like a blanket statement, but that culture can go too far. And I feel like it goes too far when people think, well, I don't matter. And my pain doesn't matter, and my pain won't affect me, because I think that's like the most hubris I can imagine, because it does affect you. It will affect how you treat other people. It will affect your technical performance. It will affect a lot of things. And, we need to like admit we're human, and what in the moment, in the middle of surgery, I think what we need to do is listen to our body. And when it says something to us, realize like, oh, all right, well, this is just Mother Nature's way of reminding me, like, I need to sit up straight, or whatever it is.
Yeah, I think you're absolutely right. And I really want to get into kind of this kind of discussion of pain in the operating room, and more than just physical pain. But I want to draw a highlight to a couple other things that you talked about in kind of the tips and tricks section of this is, and the body awareness is a huge part of this. And I'll just make a quick, plug. I started yoga for flexibility. And one of the huge secondary benefits I got out of it was body awareness and learning what different parts of my body were doing in space and how to feel that. And that helped me tremendously in the operating room. And one of the concrete examples I give trainees all the time now is, let's say we're doing a big open case, leaning over the abdomen or wherever we may be. You'll feel all the strain in the muscles in your back. And one of the easy things you can do is, to use a yoga term, is use your front body. So start using your front core, abs, and other parts of your body to take some of the strain and pressure off your back body or your posterior chain, whatever lingo you want to use. That's a very concrete example I use on a probably weekly basis when we're doing open cases to help the residents and trainees understand how they can preserve their posture and their pain a little bit better.
Yeah, yoga is a good it's a good option for a lot of people. I don't have the patience to do like a full hour, but I have found these little 20-minute like morning yoga things that you can do online. And for me, and I'm not as consistent as I wish I was, but I find that that's like kind of the limit of my attention span, but it still really does for me almost what an hour would do. And so, and especially I'm super flexible. So I've actually had, therapists tell me I shouldn't do too much yoga because then I'd be a noodle. But I found that especially when I'm tight forward, which is what we all tend to be, that does sort of like, I don't know, lengthen, to use a nice yoga term.
Yeah.
And yet I can pull it off on a regular long-term basis better than I can do like a longer session. So if you have a low attention span, consider that one.
Oh, listen, I started with 5 minutes and I'm up to 20 minutes now, but that's how I start my day every day. And I tell you, it has made a tremendous difference in how I feel in the end of the week in the operating room. Tremendous difference over the last few years. The last thing I want to draw attention to before we get into kind of some of the pain concepts here is the micro breaks. And we've talked about this in other podcasts in this series, how important micro breaks can be. And if you look at almost every industry other than medicine, micro breaks are part of the culture. And it's every 90 to 120 minutes of work, a 7 to 20-minute break. And I know you're talking just 60 seconds for surgeons. It improves happiness, efficiency. You lose nothing, and actually you gain more by taking those breaks. So I've incorporated them into my operating room too. I force people to go to the bathroom. I force people to take breaks. I enjoy taking the breaks. And there's so many team building qualities that it allows you to do too. Say, listen, I'm taking a 5-minute break. Now resident, chief resident could take a junior fellow and the chief can work together. It gives people an opportunity to kind of build and work together and encourages kind of a healthy break and check both for physical, mental, and emotional well-being.
Yeah, absolutely. And I think, I remember when I first started telling during long like microscope cases that I wouldn't tell at first. I would ask the resident, like, do you want to just scrub out and, just 5 minutes, go to the bathroom, grab a snack, whatever. And they'd be like, no. And I was like, no, I really mean it. Like, I'm not just asking like other surgeons will sometimes ask, and the expected answer is no, so that you can prove that you're the man. No, I'm like, really. And fine, I had some that just wouldn't. And I was finally like, okay, I'm telling you now, you must go. And then some of them would sort of grudgingly go, but they would come back and they'd be so much more useful. And then I also realized that like a lot of times I would let the scrub come in just to, whack under the microscope or whatever so I could see. And she would be like, oh, so that's why you do. So to me, it was this awesome sort of a opportunity to like educate her a little bit more about what we were doing and why in like a non-pressured situation, and give the resident break and get the resident back performing better. So you're right. There's just tons of, sometimes unexpected benefits of those things. So yeah.
Yeah. And the last point of that is, if you ask a patient, would you rather me standing over your body for 6 straight hours, or would you rather me go to the bathroom, maybe get a little snack, a cup of coffee while you're safe, and make sure that I'm fully into you when I'm there? They're all going to say, yeah, go take the break. I want your best all of the time. Right. I mean, that's what they want.
But we were trained. I know you were trained the same way, that's some sort of like, oh, what's the right word?
Weakness.
Big no,
Yeah.
you left the hour, and it's like, well, this patient was rock solid and I'm, 30 seconds away. So yeah.
And yeah,
I
and
think changing that culture though is really, really hard. And the only way it will change, I think, is if as attendings we model it. And when we, people now know, like when Chrouser asks you if you want lunch and you want lunch, say you want lunch, it's okay. And it's like, but that's not the same in all the ORs, even now. And I'm not saying that, during every surgery that everyone must take a break. There are times where, it's not appropriate, but, most of the stuff we do is elective and most patients are stable. And so self-care's, a reasonable consideration, I think.
Yeah. And it's the hubris that carries out of the operating room too, right? Is to say, I'm the only person who could do this at this moment. No, we've got great members of our team. We've got great partners. That's why we train them so that, they can do this when we're not there. I mean, that's the whole point of this. And stepping away from your own ego is another great, I would say, behavior we can
Model.
model. Yeah. Thanks.
Really true.
Good. So I know a lot of your interest is also in pain having multiple senses of that, not just physical pain, and how that can affect the way we perform. So take us through your newest iterations and your newest thoughts on pain in the operating room and how we manifest that and how that can, affect our patient care.
Well, from the standpoint of physical pain, it really does lower like the irritability threshold. So your ability to manage a stressor when it comes along is depressed. You're more, as my husband say, in your lizard brain, more sort of knee-jerky emotional than you would be. And that, when I say emotional, I don't mean like crying emotional, I mean like angry. Your frustration tolerance is lower. And all of that impacts how we treat our teams, and the way we treat our team as the leader influences how our team performs, because the team's performance in general is all about communication. Like, there has to be psychological safety in that room. People have to be free to speak up when they see something. If the patient's really going to be safe, everybody on that team needs to be able to do their job without worrying that someone's going to mock them, cut them down, write them up, whatever. And I think that physical pain robs us of the ability to kind of be the best leaders that we can be. And ironically, we tend to, when we're stressed, also, when we're stressed, we also get into this mode of kind of, narrowed thinking, and we get snappy at other people, and we can have that sort of same effect, negative effect on our team. And unfortunately, under stress is when you really need your team, right? You need them to give you extra ideas when, when something's going sideways and you can't think straight. You need one of them to like call and say, hey, can you send another nurse in this room? We've got issues, or whatever it is. And yet, if they're not on your side because you've alienated them for whatever reason, they can't function like they're trained to function, or they're afraid to function. Like, I did a study where we did interviews, and one of the nurses was like, well, at that point you don't want to poke the bear. And that's how people just get quiet. And I don't know if you've ever walked into an operating room and it's like too quiet, and you already, you just know, okay, now's not a good time to visit, and you just turn around and leave, right? That sort of, it's hard to label it. In the literature, it's called sort of intraoperative tension. There's a lot of different ways people try to describe it, but essentially people aren't talking. They're not talking about anything. There's silence, and there's this angst to that silence, which essentially means no one's going to say anything because they don't want to poke the bear. And you, as the attending surgeon, are usually the bear. So realizing that, you have this sort of outsized influence on the milieu is important. We're working on a paper now that's looking at like negative contagious emotion in the operating room, which runs downhill more efficiently than it runs up. And so again, as the surgeon, you're sort of on the hot seat for that emotion and that negativity. And in some ways, that's good news, because it means that we also hold the key to changing that milieu and improving the psychological safety and learning some, learning about our own reactivity and things like that. But when pain's involved, it's really hard to control. So I think that's why it's so important from a preventive standpoint to take as much physical pain out of the equation as we can. But the processes are the same, regardless of like what sets us off, whether it's, our instruments not being cleaned or the change of shift happening right at the critical portion of the procedure, or whatever those things are that sort of get you unglued. That same downstream, negative impact on the team's function can kick in. So I feel like, ergonomics is one little slice of a very sort of bigger kind of socio-technical system in which we function, but understanding that, like, as a surgeon, we're in a critical position, which gives us power in a good way and a bad way. And so I think kind of making sure that we're the best us that we can be is includes making sure that our equipment's set up right, and that we break and that we take care of ourselves, but also just being aware that how we treat other people really does have an impact on how surgery goes and how the patient does.
Yeah, tremendously important point. And I think that the negative contagious emotion, I got that right. That's what you call it. Yeah, that's an incredibly powerful kind of term that we all experience and we've all been guilty of in our careers and lives. And listen, I know the literature on mirror neurons and kind of that is a little bit controversial, but it's certainly true that we can impact the way an operating room is functioning, good or bad. And it takes a whole lot of emotional intelligence and self-insight to understand when you are the cause of that. And that comes with practice and it comes with experience, but it certainly can be improved. Do you have any, practical advice on, if you find yourself in that situation, what can you do to kind of alleviate that quiet silence, that tension that's going on?
Well, my strategy often is just like name the elephant in the room. I can tend to be pretty blunt. So I'll just be like, well, it's really dead quiet in here, which means that, whatever. And sometimes I'll just come out and straight up say to whoever, like, if I know it's on me, I'll just say it right out in front of everybody, because I think that is the right thing to do, just to manage it as soon as it can be managed. But I think it also speaks to the other people in the room that if they're ever in a position where I've said something, that maybe they'll realize that, oh, she's the kind of person who's going to come around later and own up to it. Like, to me, it just speaks to somebody's character if they're willing to just come out and say, yeah, I was wrong, or whatever it is. Or sometimes it's just like, okay, I think we might have crossed wires here, and this is, and just sort of try and solve the issue. Sometimes there's just things that can't be solved in the moment, right? But I guess I usually just try and say, or I'll make a joke about, wow, it's really quiet. Is somebody licking their wounds? If it's something that I really think was, that people will like laugh about and kind of can move past. But usually, if I feel like it was on me, I just will take it and see if I can diffuse it.
Yeah. And sometimes you don't know what's going on, but just calling out, be like, hey guys, like you said, it's awfully quiet in here, or reflect back what you think is coming up. Like, I'm picking up this. Am I on here or am I off? And that helps really build team camaraderie too, because it tells your team you're really into them too, right? We're all in this together, and I'm really into you just as you're into me. And I think it's an important part of what we do.
And I think too that for so long, surgeons expected the staff to be attuned to their every need, and they didn't even know their staff's names, and that was the MO for a long time. And I just think that's wrong, and I'm terrible at names, and I ask people their names all the time, but I'm just going to keep asking until I learn, because I want to know. And because I feel like that makes people understand that I care. If I can't get your name through my head, then, that means that's a lack of effort on my part. I really need to do better. So yeah, I think you're right. There is sort of a sea change in, our culture, but not all roles have quite caught up with that. And I would say probably surgeons will the most clueless in terms of, all the research says that like they'll do a study saying, oh, how's the communication among this team? And the the nurses, the anesthesiologists, everybody agrees it's lousy except the surgeon says it's great. So we have a lot to learn, and getting over ourselves is probably the first lesson we should learn.
Yeah, it's the surgeon-centric vision of the universe, which is false. We'll just put it that way.
Well, no, the difference between a surgeon and the difference between a surgeon and God, right?
Tell me.
God knows he's not a surgeon.
There you go. There you go. No, and I think the other strategy is sometimes you'll pick up that something's amiss in the operating room, but you just can't address it. Address it after the case. There's lots of downtime. These are people you're going to work with on a daily basis. And I've had that happen too. And I've even had it where I was out of line, but I couldn't even address my own being out of line at the moment because things were critical. And at the end of the case, either publicly or privately, whatever's most appropriate, say, I was out of line and I apologize and I need to tell you that. Or I was appropriate and you were out of line. Let's talk about it too, is a really important conversation that also tells somebody that you care about them and you care about how that patient's doing. And that's hard to do, but it's a really important conversation.
Yeah, that's really true.
Yeah. And, one of the things we've talked about before too is pain, whether it's physical, emotional, psychological, also leads to disruptive behaviors. So tell us kind of where you're going with that and what your thoughts are here.
So it's sort of related to what I was saying before about, all these things that can come in and frustrate us. And, and frustration sort of taken to the nth degree becomes anger. And then, given the right opportunity, anger can be quite disruptive. And, like the research shows that nurses and providers in general, I should say like non-surgeon surgical providers in general, show tremendously high rates of exposure to disruptive behavior in like the perioperative setting, even now, higher than you would think. And so, it's continuing now. And some of that is perception. If you ask, you ask surgeons if what they did was disruptive or hurtful or inappropriate, they'll say no. And I was just advocating for the patient. And then the person on the other end of their rage or whatever will be like, oh no, that was not, that was not appropriate. So some of it's a matter of opinion. And some of it is that we actually aren't aware of what we're doing as disruptive. But what my interest has become more related to trainees, because what does that do to someone who's trying to learn? And I did a little qualitative study of trainees' exposure to disruptive behavior, which was almost universal, and they were such good assessors of the operating room in terms of being able to tell whether it was psychologically safe, being able to and like amazingly perceptive, given that they hadn't they weren't very experienced, but very clued in. And I think that when you're in a situation where someone else is being disruptive and you're trying to learn, well, it's just not happening. or you're rapidly learning that you don't want to go train as a surgeon, and so what students are we losing to that type of behavior? But also, when we're disruptive, we're to our residents teaching them bad patterns. We're allowing ourselves to, lose it because in the moment it might feel good, but as we talked about before, that doesn't help our teams. And no one can really learn well in that context, when they're afraid to poke the bear. You can't ask the bear a question about the surgical anatomy, right? And I remember feeling like that in residency, like, gosh, I really want to ask this, but like he's in such a bad mood. There's no way. And I guess I just don't ever want to put a student in that position.
Yeah, no, I mean, you used the term before, lizard brain, and we can put people into their lizard brain and basically put them into their fight or flight response, right? And there's a reason lizards don't do surgery to make right to make light of it. But you cannot be an effective learner. You lose all higher function and executive function when you're in your fight or flight response. That's why it's just two choices. It's fight, flight, or actually play dead. And neither of those are conducive to a good operation and taking good care of patients. So yeah, we really do need to think about how we do that in terms of our learners, and as you said before, once again, modeling behaviors, creating a psychologically safe operating room. Hugely important.
Yeah,
And
not easy.
no,
But
definitely not easy. And I'll just throw out one other anecdote, not from our field, but the airline industry, the classic story they talk was the Korean airline kind of hierarchy from 25, 30 years ago now, where literally there was such a hierarchy between the pilot and the co-pilots that planes crashed because co-pilots wouldn't speak up.
mhm.
And we see, not to the same degree, but you can see issues happen in the operating room if people are scared to speak up. And I just want to give credit to a phenomenal resident for, something that happened a few months ago. But, we were doing a case and things were really challenging. And I was planning on fixing something in one vein. And this resident said to me, well, why don't we do this the other way? And it's literally something I taught that resident a week before. I showed them how to do it. And I was not in the right mind space, but they kind of felt safe and were able to speak up. And I'll tell you, the patient would have been fine either way, but their way was much better than what I was planning on doing. And I gave them a lot of credit. And that's what you want. You want people to speak up and protect you and protect your patients. And I advocate for the best outcomes. And psychological safety is essential for that.
Absolutely. But I think it all goes back to how we were, we were trained in a context where humility was not held up as a value. And I think that's what has to change. We're human, we can make mistakes, we don't always know, we can go into our lizard brain and not think about the full differential diagnosis like we should. And a really strong team can save you then. But you have to have cultivated that team. It's not going to show up for you if you haven't showed up for it in the past. And I think we need to internalize that, realize that takes humility on a daily basis, whether it's asking their name again, or whatever it is, to get through to people that, we're human like they are, we care, that, and we'll all come together around this patient and give them the best care possible.
Yeah. And for people who struggle with this, I've adopted kind of the Army model for thinking about how to, kind of how to take care of your team. And in the Army mantra, it's soldiers first, and then it's mission, and then God, country, everything else that you hear about. But if you don't take care of your soldiers, if you don't take care of your team, there is no mission. There is no patient care if you can't take care of each other and work together. There's nobody who can do this on their own. And so take care of your people first, and the patient care will follow from good care of the people around you.
Well said.
Thanks.
Very well said.
All right, Chrouser, we're getting close to the end. I want to be respectful of your time. What haven't we covered that we need to today? What do you want to talk about? Anything else that you want to bring up?
Well, it was just there's one other little thing I recently did an interview of it, a senior surgeon from the University of Michigan who retired a few years ago, because I knew he had had some musculoskeletal issues that had shortened his career. And one of the questions I had asked, because what I wanted to do was help the residents understand that this can happen to anybody. This can happen to somebody you know and respect. And but one of the questions I asked was, well, how did you sort of get past the fact that you needed to retire early and stop operating? Because, it was like a high powered surgeon in oncology, and, did big cases. And he said, my pain was so bad by the time I stopped that I wasn't sad to stop. And I had been hurting for 15 years. And I was just totally taken aback, because it was like this idea that he did push through and push through and push through until he couldn't push through anymore. But like, you could just tell that by the time he had to retire, that it was just so bad that like the joy was gone. And that made me super sad, because it made me realize that like, and in talking to him, there were, really practical things that he could have done. He might have been able to have a full career, even knowing like the little things that we know now. And this field, by the way, is like not mature. We have lots to learn, but just hearing that story, and that, it wasn't that it went out with a bang, it went out with kind of a whimper in a way, like 15 years of just not, he said, I would dread going to the OR. He's like, I used to love it. And so to me, that was just so underlined, like, this is what we want to prevent, is, this, like, not just that he had to like endure all that, like physically, but just the sort of sadness of, missing the opportunities. Because even he said that, I didn't teach as well. I wasn't as patient, and realize that like those are opportunities lost forever. And that's to me, the big picture of like what we're trying to prevent in this space, and give people the tools to have a long and productive career.
Wow, very, very, very well said. So if I could pose one more question before we get to the summary here, what's the future in this field? Where are we going? How do we get better? What are you interested in? Where's the field going?
Well, I think we're going to get better because the technology is getting better. So I think we're probably going to be able to design wearables that are very much focused on like real-time assessment, or at least surgeon specific assessment, that will help us know, when in the middle of a case, something needs to change, because we've sort of, we might not feel the pain yet, but we're going to later if we don't move, which would essentially help when to stand up. If you don't have that postural reset thing down yet, the technology might help us. So I think that's probably going to come online. I think that also right now the micro breaks are very generic. And what I would like to see is sort of breaks, stretches, even potentially like exercise programs that are developed, that are personalized. They're personalized based on what type of surgeon you are, what type of cases you do, how often you do them, and your pre-existing sort of musculoskeletal situation. So that I think that would really target and help with prevention. And some of that could be outside the OR stretches. It could be exercises. I think there are a lot of ways it could go, but more personalized, more personalized, like physical preparation. But then there's also some interesting work in exoskeletons and in aids that can be used to support surgeons while they operate, and to really think about, how can we get the patient to us, or us to the patient, in a way that maintains sterility, but also, decreases the stress on our musculoskeletal system. So some of those are already commercially available. A lot of them are sort of still in the prototype mode, but I think that some of that will hit the market in the next few years. There's loops I've heard, I haven't tried them yet, that where you don't have to look down. Actually, there's like you just look straight forward, and you're able to see it at a right angle, essentially. So yeah, I think tech will help, but it's never going to replace the fact that some of it we're going to have to do the hard work.
Yeah, very cool. Mike Joyner, who's an anesthesiologist at Mayo Clinic, he talks a lot about how the similarities between the operating room and athletics. And while we're not necessarily athletes, we're definitely performance professionals, right? In what we do. And it would be interesting to see if we ever get to the point where we kind of have training rooms, right? Where there's people to kind of assess before and after your day in the operating room, warm up, cool down, people who are involved in your care. And you can imagine, to use kind of the administrative term, the FTE for someone to take care of your physical health or help you with that would probably be would return in dividends on sustainability of surgical careers.
Absolutely. Absolutely. I think that, my vision one day would be when I retire, I'm going to start, the equivalent of, what elite athletes have, where you have all that physical stuff, but then you have, the equivalent of sports psychology, but it's surgeon psychology. There's all these pieces of what we do that at elite levels, they have somebody designed to support that so every aspect of your performance. And yeah, I think that if society was really understood the cost of losing someone early, there would probably be willingness to support that. But we really have to show that ROI, and that, of course, is the hard part. We all have a sense that it would make a difference, but before anyone's going to put their money in it, we've got to do the trial. So stay tuned.
Appreciate it. Can't wait to be a part of it.
Sign you up.
Yeah. Well, Chrouser, I can't thank you enough for taking the time today for this fascinating conversation. I had a great time. I just want to highlight some of the really important things you said kind of over the course of the last hour. We were talking about sustainability, and we started off with kind of physical well-being, but you highlighted that each of us have individual components. There are environmental components that can affect the way we perform and the way we feel in the operating room, and paying attention to those, not only being self-aware, but being aware of what's going on around us, are incredibly important. You highlighted that this is a real issue for surgeons, and not just daily and weekly pain, but these are things that can lead to early retirements, undesired retirements, because, as you said, you can lose the joy because you're so uncomfortable. You are in so much pain that it no longer becomes an option for you to continue doing the work that you love doing and to experience the joy that brought us all to the operating room. You gave us some real practical tips for improvement, pre-operating room stretching. You talked about the environmental checklist, which I'm going to bring into the operating room potentially as part of our timeout now. Making sure tables are adjusted as part of that timeout, screens, kind of everything in line and ergonomically sound, rather than scrambling during the case, bring this pedal over here, move that over there. You talked, I think really importantly, something I already do, but I'm going to reinforce more: micro breaks, postural resets, being more aware of these things, and you actually using the terminology in the operating room. And I think using the terminology helps too, especially we're so scientifically minded, or at least we tell ourselves we are, that using terms sometimes helps. So we'll voice them and call them micro breaks and postural resets, and just highlighting once again, decreased pain, increased mental acuity, no difference in case times. That's what the data shows us. So there's really no reason not to do these things. And then we talked about how pain affects us, and how literally we talked about the lizard brain, which was kind of fun for a little bit there, but irritability thresholds and how we treat our teams and set examples can be the difference in a great case and an average case or a complication occasionally. And really taking care of the people around us, avoiding negative, contagious emotions, being aware of how disruptive behaviors affect our OR teams, our trainees specifically, and that pushing through pain and discomfort is no longer a virtue. Yeah, we're surgeons. There's times we're going to have to do this, but this is certainly not a virtue. We need to take care of ourselves. We need to take care of each other. So thanks for everything you said. I know there's people who are going to really benefit from this conversation, and I greatly appreciate your time.
Well, thanks so much for having me.
Talk to you soon.
See ya.